Kushalnagar said this is family
Okay.
style, right?
It is. It is. Are we okay? And we are live. Good evening. My name is Dr. Gigi El-Bayoumi from the Rodham Institute, and I am so happy to welcome everybody. The Rodham Institute, as you know, is dedicated to improving health equity in Washington, D.C. I'm just going to give you a little bit of an update about what's happening in COVID, and then we'll go right into our wonderful panel this evening, which I'm so excited about. So COVID in Washington, D.C., the numbers are starting to go up again. And what we're seeing is frontline workers, such as sanitation workers, such as teachers, such as home health aides, are being impacted, and we're seeing a disproportionate number of deaths. The vaccine rollout has been less than smooth, as any of us who live in the tri-state area can attest. As a physician taking care of patients, we can't vaccinate our patients. They have to be vaccinated. If they have to live in DC to get vaccinated at GW, but we're trying to work that out so that it doesn't matter where you live in the tri-state area to make it easier. I would really recommend that you go to the DC Department of Health's website to get the latest up-to-date information. I can tell you that I took my parents this past Friday to United Medical Center, where they got vaccinated, and it was wonderful. But we at the Rodham Institute are planning to host, to be part of a mass vaccination campaign on the road, where we will probably have it at like Southeast Tennyson Learning Center or other community venues to vaccinate people and to get people vaccinated as much as possible. We are all part of the Black Coalition Against COVID. So if you want up-to-date information, please visit blackcoalitionagainstcovid.org. So without further ado, I am just delighted to introduce the panelists that are here with us to have a discussion about the deaf and hard of hearing community and how disparities, health and otherwise, impact this special community. You know, we're in Washington, D.C., where the only deaf university, Gallaudet, exists. And when I was training for during medical school and residency, there was really nothing about how to care for this special population. And I want to share with you, just before we were starting the webinar, I was having difficulty as a hearing person because my colleagues on the panel were signing, and I'm like, what are they saying? So that just gave me a little taste of what people who are deaf or hard of hearing experience on a daily basis. We also did not have, Zoom is not equipped easily to be able to have, what am I looking for? Auto writing capabilities so that people can see what's the questions that are being asked. But I think we've got ways that we're going to work around that today. So, you know, I always say you guys are a family in the audience. Our guests are certainly new family, and we'd like to welcome them. But if things are not perfect, please, I think that this is actually helping to reinforce what the issues are and not being inclusive and what that does in terms of our communication. So it's kind of like we are illustrating some of the issues already. So without further ado, I'd like to introduce our illustrious panel. And Dr. Huang is one of our colleagues at Unity Healthcare. He is a family physician. Dr. Poorna Kushalnagar, please forgive me if I've mispronounced your name, is Special Assistant to the Provost for Research and Engagement. She is a professor and director at the Center for Deaf Health Equity at Gallaudet University. Welcome, Doctor. Ms. Stacy Abrams, who is CEO of Y-Sign. And then we've got, I want to say, 3 interpreters with us. And I'm sorry, I don't know their names. Perhaps if they could introduce themselves, that would be helpful. Maybe, you know, I've got it by 1, 2, 3. Maybe I could start off with ASL interpreter number 1. What is your name, please? Can't hear you. Okay. That's weird. Okay, let's start with, well then let's try ASL interpreter number 2.
Hi there. My name is Chris. I'm one of the 3 sign language interpreters.
Thank you. Number 3. What's your name?
I'm Christina. I'm one of the sign language interpreters tonight.
Thank you. And number 1, I don't know if the sound is still distorted.
Is this working now?
Yes, it is. Perfect.
Okay. Hi, my name is Jennifer Vold. I'll be interpreting Dr. Kushalnagar's comments tonight.
Wonderful. So let's start off by getting to know you. Let's start off with you, Dr. Poorna. Tell us about yourself and your career. And we're going to really use this time for you to talk about what you feel the rest of us should really know. But tell us about yourself first, please.
Gladly, it's my pleasure to be here. Thank you for extending the invitation, and thank you especially to Dr. Huang for bringing me in tonight on tonight's panel. My feelings about deaf and hard of hearing people's access to healthcare during the pandemic is truly mixed. I think that deaf and hard of hearing people need to have complete access, and that's not the case yet. I'll talk more about that later this evening. I do see improvements through our work at the Center for Deaf Health Equity. We have gotten emergency funding from the National Institutes of Health to do a COVID-19 investigation with deaf and hard of hearing adults in the United States, specifically people who use American Sign Language. We've interviewed about 250, roughly, people. So I'll be sharing preliminary findings or preliminary results from those interviews during the panel today.
Thank you. And tell us about yourself. I mean, tell us about your personal story and how you got to Gallaudet.
Oh, sure. Happy to share a little bit about myself. I was born in India. My family moved to the United States when I was an infant. I grew up in a family that was all hearing. I went to public schools, a mainstream school that had deaf and hard of hearing services. Both of my parents are university professors or were university professors. So I had access to information by way of my parents, regardless of the fact that I was deaf and they were hearing. So I was able to navigate various challenges throughout my childhood and adolescence. I then went to Gallaudet in the early 90s, late 80s, early 90s. I went to Gallaudet, got my degree from Gallaudet University. Several years later, after having 2 babies, I went back to school and completed my PhD. I originally started off as a clinical neuropsychologist and then transitioned into developmental cognitive neuroscience. And then I did my postdocs in health services and patient-reported outcomes research at the University of Washington and then at the University of Rochester. I then came back to Gallaudet University about 4 years ago, and I've been here ever since doing a lot of health-related research, primarily focusing on populations and health research within the deaf community and those who use ASL. Most of my work focuses on within group assessments to identify specific groups within the deaf community who are at risk for particular health outcomes. And I do this work, I've done this work for many years, and a lot of research often lumps the deaf population into one group and then compares the entire deaf population with a hearing population at large. And that is fine in the sense that it still gives us important information, and it still does show that there are health disparities when it relates to deaf people as compared to their hearing peers. The issue is that the pooled approach masks the real differences within the community. And so it overlooks, for example, people who are truly at risk and need the most help.
Well, that's sort of the issue that you have with any marginalized or minoritized communities. There is this tendency to lump all African Americans, all, you know, deaf and hard of hearing people as though they're monolithic. And actually, studies show, as I'm sure you can speak to better than I, that there's actually more differences within communities than across communities oftentimes. But thank you for that. And we have something in common. My parents are both retired university professors too. So it's challenging to grow up in an academic household sometimes. Too many discussions, but anyway, I digress. Ms. Stacey Abrams, you're the Stacey Abrams from Washington, D.C. I think we are so thrilled with Stacey Abrams down in Georgia. But tell us about yourself. Tell us about your company. And
I'm sorry that I'm not the Stacey Abrams from Georgia.
well, we welcome all Stacey Abrams. But please tell us about your work and yourself.
Sure, of course. I actually have a funny experience related to being Stacey Abrams. I was in the hospital last year for surgery, and all the nurses were talking about how Stacey Abrams was in the house, and then asking questions why Stacey Abrams needed an interpreter. And then when I arrived for check-in, they took one look at me, put two and two together, and realized that while our names are not spelled the same, they sound the same. So I think they were a little disappointed to see a young white woman show up. But I have found that I do get mail sent to the Stacey Abrams, and I have to say I doubt she gets my mail. But anyways, I'm from Arkansas. My sister is also deaf. We have grown up in this system, and my parents sign. Fortunately, they actually learned to sign, which is not necessarily the case for most folks. I was in a very small town where I grew up, but luckily my parents had a lot of support from the deaf and signing community and learned the language that way. When I arrived at Gallaudet for my undergraduate studies, I found myself really interested in biology and psychology. And I thought about going into therapy. And one thing that really struck me was thinking about children whose families are hearing and perhaps don't sign, and how that has an impact on family dynamics. And so my passion really lies within working with hearing families who have deaf children. So through that career goal and that path, I was a program coordinator where I served families all over New Mexico and Arizona. And my goal and position there, rather, was to pair deaf children and their hearing families with deaf adults. And that partnership was intended to provide the parents with resources like learning how to sign, teaching them about the fact that there is a deaf community and that they exist, and things like that. About 4 years ago, I moved to Washington, D.C., and my day job is I work for the Clare National Deaf Center. I am a training coordinator there. I mean, it's my side job, so to speak, but I created the hashtag Why I Sign, was really embedded in my goal of creating that connection between hearing parents and deaf children, because I know that there is a want on the behalf of the deaf community to support hearing parents who have deaf children. And I decided to leverage the power of social media to create a connection with those folks who are from those backgrounds. And so it's been about 5 years since I launched my little side project. And since then, I've given a number of presentations, which has been really wonderful. I also am a mom of 2 deaf children, so I have another interesting perspective as well, just as someone who has children. And it's interesting to see how my children have access to information and how my children's peers, some do and some don't have that same access. It's actually funny to see Dr. Huang here because he is my main provider, my primary provider, and it makes such a difference to know that my primary care actually is fluent in the language that I grew up using.
Well, thank you. And where in Arkansas are you from?
I grew up an hour north of Little Rock, so it's in a farmer town. My family still lives there, but I went to a deaf school in Little Rock. I was
Got
the
it.
first baby in the parent-infant program. When I was 18 months old, I was the first student in their program, and I think that instilled within me an interest in early learning and early language acquisition and the interest in seeing that language and knowledge and access develop.
Wow. So we are honored to have a first person, a real trailblazer. Welcome. Dr. Huang, welcome, and please tell us a little bit about yourself and how it came to be that you work with the deaf and hard of hearing community.
Sure. Well, thank you so much for having us here tonight and starting the conversation. And so basically, both of my parents are immigrants from China and Hong Kong. Both are deaf. And so this is how I became fluent in ASL from learning from my parents. In fact, I'm their first child, so I actually was a little delayed in my verbal speech because I was signing from the beginning, and my first sign, I first spoke like milk, and so so that's how I learned American Sign Language from my parents, and so. I think growing up and seeing the different programs that help elevate their health, like in terms of like access to training programs, to different resources, I really saw how those programs really elevated our family's health. But then at the same time, growing up, I saw different ways that my parents' health suffered because of different communication barriers, not having, my dad had developed gastric cancer or stomach cancer before the ADA. And so he didn't really have access to interpreters all the time. He didn't have that protection in place. And so that really led me, after I became a family medicine doctor and moved to DC, I really wanted to focus efforts on reducing communication barriers and health disparities within the deaf community. And so that's why I created this clinic at Unity called the CODA Clinic. So it's a comprehensive medical care for deaf adults and children. And so CODA in the deaf community means deaf child of deaf adults, and so I really wanted to give respect to my parents and for everything they've given me, and so that's how I got involved with starting the CODA Clinic, and I met Dr. K and Stacy, Ms. Abrams through that work.
Wow. Well, I'm sorry about your father. Can you tell the audience, because not everybody knows what ADA is. What is that?
Sure.
And how did that impact your dad?
Yeah, sure. So the American with Disabilities Act was passed in 1990, and it's an act to protect the people with disabilities, and in terms of different places and businesses, they have to legally provide accommodations. So for within the deaf community, that means kind of matching their mode of communication and providing accommodations to meet their communication needs, whether that be through an ASL interpreter, if you're deaf-blind, having a deaf-blind interpreter. So there's a variety of ways to meet the standards of the ADA, and it actually just celebrated the anniversary recently.
Yes, I know. And the ADA also protects people who are working, that they cannot be discriminated against for any health conditions that they may have. So they can't be fired because they have diabetes, for example. And I think that these protections become particularly important during a time of COVID, right? And a pandemic. And sadly, because of the reliance on employment being tied to insurance. So thank you for sharing. Dr. Poorna, tell us a little bit about your work. Would love to hear more specifics, especially in the context of the COVID pandemic. We know that there are groups that have been disproportionately hit and actually lives lost as a result of COVID. Certainly people from poor socioeconomic backgrounds, communities of color, undocumented immigrants, people, as I was mentioning, the frontline workers, sanitation workers, teachers, healthcare workers. But tell us about how COVID has impacted, you mentioned at the outset of your comments, the deaf and hard of hearing community, but please talk to us a little bit more about your specific research and your research interest.
I'm glad you asked that question, and I'm happy to share what we've been seeing. So our work is still in progress. We have published one paper so far. We have two more that are under review now. One should be submitted for publication soon. What we have seen, to summarize, is a major concern around access to information about COVID-19 in American Sign Language. These concerns were raised loud and clear back in March when the pandemic hit, because information was being given in English and a lot of times in spoken language formats and in press conferences, things like that. And interpreters were not available. Videos were not interpreted into ASL, despite the fact that the National Association of the Deaf repeatedly requested that videos be translated into ASL. The CDC eventually started to interpret their videos. That took about 3 weeks after they announced that we were in a pandemic. At Gallaudet University, we got a grant around that same time in the month of March and April to do the same sort of thing. And there was a lot of doubt, a lot of uncertainty, a great deal of fear, worry, and concern about quarantining, deaf people remaining at home and being lonely, having less access to food. And that is more prevalent among deaf people who are very young, single, and female. So that was roughly March, April into May, what we were doing. And then, as I just said, we did follow-up interviews with those same group of people after we had done the baseline assessment. So those interviews were done from August to November. And I took a quick look. So we have a very preliminary analysis of the data from the baseline to the follow-up interviews. And I do see a change. I'm happy to say that the extent of concern and worry in the deaf community is less now than it was early in the pandemic. I have a firm belief that that is because of the efforts that the National Association of the Deaf, state agencies of the deaf, every commission, there are a number of states that undertook a great deal of effort to make all of their videos available in ASL and make them available on social media so that they could reach the wider community. So I think that these preliminary results are because of the efforts that were done on the part of state associations. Now, that said, it's not that there's no concern or no worry, it's just less than there was earlier. There's more knowledge about COVID symptoms, more understanding of why people are wearing masks. People are able to explain why social distancing are important. So we ask these questions at baseline and follow up. So we saw increases in the follow-up, which is good. Again, I believe that that has to do with information being made available in American Sign Language. So the access to information, on the access to information front, we have some good news, but in terms of access to actual healthcare, we're still seeing disparities. Mm-hmm. We asked participants if they had gone to an emergency room, if they had an overnight stay at a hospital, and then we proceeded to ask if they had requested an interpreter. Then we asked if they made the request, did they actually get an interpreter? We asked if the interpreter was able to understand them. And the majority, I would say about 70% of the people who had spent at least one night in the hospital, actually I should back up a little bit, of all the people that we asked, about 10 to 12% of that sample said that they did end up having at least a one-night stay in the hospital during the pandemic. So that is about 10, 12% of the 250 interviewees. So it's a smaller subset. So of that group, about 7 70% said that they got interpreting services. 99% requested these services, but only 70% got interpreting services. About 50% said that the interpreters understood what they were saying. Mm-hmm. We asked them what barriers they faced. Many of them were due to video remote interpreting services. So this is when they're having access to interpreting services via the internet and on a monitor. They talked about a lot of technical difficulties. So when the video image freezes, that's the equivalent of sound dropping out. And so it starts to make people unintelligible. So I add that just to say that they weren't complaining about the interpreter's language proficiency and their interpreting skill, but they were commenting on the barrier that technical difficulties created in making each other mutually intelligible. We also saw a trend, and again, this is not, we have not done a full analysis, but I can say so far that we're seeing a trend that people who go into emergency rooms typically get interpreting services by way of VRI. Very few people had an in-person interpreter. Those who had an overnight stay in the hospital were more likely to have in-person interpreting services than solely VRI. So that's one area we are thinking about taking a further look at and seeing why there is that difference in the provision of in-person interpreting services once someone has been admitted to the hospital versus at the ER. But I think I'll leave it there for now.
So thank you. What is VRI? You mentioned in-person versus VRI.
Video remote interpreting.
Okay, all right.
So you access an interpreter much like how we're, oh, you got it, okay.
Thank you, thank you. Well, I mean, I think that what you are describing is basically the pandemic has brought out or highlighted disparities that have always existed. And, you know, for people who are not sort of fitting into the mainstream, whether they be hearing or, you know, white or upper middle class or whatever, you know, that gives them privilege to get the best kind of care, that really this pandemic has helped to really uncover the weaknesses in our healthcare system and otherwise. But I think, you know, to your point, it's important to study exactly how specific populations are impacted. The mental health piece you bring up is huge. I mean, in kids, I just heard a presentation at Children's Hospital. The number of kids and young people who are committing suicide is actually going up significantly. So the issues are similar for everybody in terms of isolation and loneliness, but obviously the services and how we uncover these issues and serve different populations may be different. But I think, you know, to have that research is really crucial. So Ms. Abrams, you know, we're hearing about American Sign Language. Assume that our audience, including me, is ignorant about the different types of communication, you know, sign language that there is. Can you just give us sort of a primer on what is, first of all, spoken or signed in the United States, and a little bit about the differences in terms of language, the languages available?
Certainly. So ASL is the third most often used language in America. And it's still, despite that, difficult to find interpreters and accessibility with ASL in the healthcare field. A lot of people think that ASL is just signs that reflect English words. But in fact, ASL has its own syntax, its own grammatical structure. And for that reason, it is not just English that exists in 3D, but rather its own separate language. And despite the fact that, again, it's the third most commonly used language in the US, there are still limitations and struggles in terms of finding access. When it comes to healthcare providers and deaf people's experiences in the field, there's a lot to be said. often healthcare providers and medical students get very, very limited training when it comes to working with deaf individuals. That is especially true with deaf children. Their knowledge, their exposure is incredibly limited. And even the exposure that they do get often comes through the lens of seeing deafness as a pathological issue, something to be repaired. And that's not necessarily true. In fact, it's often not the case. While someone may consider their deafness to be a disability or something to be fixed or repaired, there are just as many people who consider that just their identity and that they belong to a linguistic minority. And so what's fascinating is that people in the medical field, providers, the system in general, expect deaf people to be able to respond to questions and analyses and things of that sort using their second language, the language that belongs to hearing people, the one language that isn't necessarily native to them. So actually recently my friend's mom was diagnosed with COVID and could only communicate by way of writing back and forth. And so instead, what she decided to do was calling through her phone to a video relay interpreter because there were no interpreters on site, of course. And so she called the video relay service, which is different from the video remote, and instead used her phone to connect with the nurse, even though she and the nurse were in the same room. And she felt quite dismissed or looked down upon on behalf of the nurse. She noticed that the nurse was consistently trying to talk over her and kind of take over the floor, and she ended up leaving. She didn't get any more information about her symptoms, her treatment, and things like that. So instead, what she did was she went home and talked to her daughter-in-law, who's hearing, and who happens to be, as Dr. Huang mentioned, a CODA, who's a nurse. And so there has been, it just so happened that the daughter-in-law saw this happen, called the nurse that had previously been treating her mother-in-law, and had a conversation with her. And because she was using spoken English, she very quickly and easily got the attention of the nurse and very quickly was able to get clarification, and with no issue at all was given the time of day. And it just so happened that because of that decision for the daughter-in-law to reach out, the mother-in-law ended up going back into the hospital the next day. And that whole notion of a hearing person having to get involved because a deaf person isn't seen as equal or isn't seen as someone who is an expert in their own lived experience and someone who perhaps is not to be trusted or not worth understanding. Deaf people are the people who should be speaking for themselves by way of interpreters. And instead, she was forced to try to go through the relay, and even then, the nurse did not seem to be interested. And of course, again, I cannot reiterate enough how much of a difference it was when the medical office heard from a hearing person, the daughter-in-law, who ended up reaching out directly. I mean, and imagine if she hadn't done that there never would have been clarification about this COVID case. And so when you think about how often that must happen, I mean, it is so, so common. And most folks in healthcare have such little experience and exposure to deaf patients and families. And I think that is something, a root cause that certainly needs some changing.
Thank you for sharing that. And of course, we hear about different groups being dismissed in that way. There is Dr. Moore from my alma mater, University of Michigan, who probably you read about. She is the physician who graduated in 2003. She had COVID. She's African American, and kept telling the doctors caring for her that, look, I'm in pain, I can't breathe, and basically she ended up dying. So we as a healthcare system don't listen to many different people. And that's inexcusable no matter who it is. And I think that the double barriers of language and communication, which is key to healthcare, right, is so important. So thank you for giving us a specific example of how that actually manifests itself. So Dr. Huang, I mean, you are a physician, you work with deaf and hard of hearing patients. What would you say to those of us in the healthcare system that we need to do differently? You know, I mean, clearly there are gaps and there are lots of gaps, but what are some things? I'm a clinician right now. First, let's talk about as an individual. What do I as an individual, what do I do? What do I need to do to respect and respect the dignity of the human being that's in front of me who happens to be deaf or hard of hearing? What are sort of the basics there?
Sure. I think there's been a lot of themes around communication. So as healthcare providers, we need to understand how our patients communicate and provide the accommodations to meet those communication needs. But we also have to think systemically, how is that flagged first from like when a patient makes an appointment, how does that patient get an ASL interpreter to come to that appointment? How is that, you know, is there a global alert in our electronic medical record? Is that documented that an ASL company was contacted and that they're sending an interpreter? Or, you know, if it's like an emergency room and you don't have access to on-site interpreters and you have to use VRI, is the equipment working? Does someone know how to use the equipment? Is the broadband or Wi-Fi strong enough to continue, be able to provide constant, smooth communication with the patient and the VRI interpreter, the relay interpreter? And so I think in terms of thinking about like making sure that we're educated in what the rights are of our patients and how to meet those accommodations is probably one of the first things. And then in terms of, I think not saying everyone should learn American Sign Language, but you could learn, people could learn a few phrases. It's like some people learn a few phrases in Spanish or some other languages. I think that it always helps with connecting with people, like trying to speak in their primary language. Taking an ASL class, being ambitious and then trying to find different resources in the community. And then, I think the third thing that we could, as a healthcare professional, we could encourage more deaf and hard of hearing healthcare workers. We could have more, there are growing numbers of doctors, nurses who are deaf and hard of hearing. And so if we have an infusion of more people with disability within the healthcare workforce that can not only educate our colleagues, but work with our patients and provide really better care to to people with similar communication styles and needs, and have an understanding of what the needs are.
And that's, I think, an important point that has been, there's been research, for example, among African-American men, that the quality of their care improves when they're seeing African-American male physicians. And so it feels to me that in responding to this COVID crisis, the deaf and hard of hearing community, like others, are sort of an afterthought. And what we're really talking about is infrastructure changes where from the beginning of planning, whatever we're planning, health equity needs to be in everything, and every community needs to be there, not just as recipients, but as to your point, Dr. Huang, in terms of being part of the leadership, part of the people that deliver the services, as well as the recipients, so that it's not just this sort of passive it's everybody being put on on equal footing, that representatives of the deaf and hard of hearing community have expertise, have knowledge, have researchers, and really need to be placed at that level. So two things I wanted to mention, then we'll take a question from the chat that came. First of all, just so that you all know, the Rodham Institute has an education council that is comprised of members of different groups, including community-based organizations, nursing, other healthcare disciplines. I'd love to be able to invite you, and I don't know, it could be more than one person, to be part of that education council, because we need for you to drive the curriculum and to help educate our learners and our faculty and our staff. I mean, we don't have anything right now at GW. I don't think GW is unique, and we need to do better. So afterwards, let's connect so that we can make sure that we can involve you in the Rodham Institute's Education Council. There's a question that came from the chat from actually a nursing student who asks how a healthcare student or learner can get involved. What is a role that he or she can play to support and to serve the deaf and hard of hearing community? I don't know who wants to take that. Any of you can take that. So are there opportunities for volunteering from somebody that doesn't necessarily know sign language? They want to be supportive to, you know, potentially educate around healthcare issues? Yes, Ms. Abrams.
Sure. Sure. So I have a suggestion. So when I was in New Mexico, and well, I was working between New Mexico and Arizona, we had a deaf school that just happened to be located right by the medical school. So for example, the University of New Mexico Medical School was just down the street from the New Mexico School for the Deaf. So because of that geographical proximity, the med students were able to come out once a month to visit the deaf school and just have exposure to young deaf children in action, so to speak, because they often see deaf children in clinic who are timid and shy because they're at the doctors. What the med students get an opportunity to see at the deaf school is deaf children being amongst other deaf children. And so their experiences, having witnessed all of that and just have been exposed to that, provides them with a little bit more of a dynamic understanding of a whole deaf child as opposed to someone who they've only ever seen in the context of an exam room. So I think what's also really unique about this opportunity is that medical students who come out to the deaf school can see how much diversity there is within the deaf community. Some deaf people who sign, some deaf people who use their own voices to speak, some deaf people who perhaps have cochlear implants or hearing aids or none of the above. And so just that rich diversity within the deaf community is something that they otherwise would never have exposure to. And so this opportunity really gives them a far more rich understanding and schema of the deaf community. So when you ask about how folks can get involved with the deaf community, I think partnering with deaf schools is a great way to give them a space to learn and ask questions of the administrators and to really see what folks, deaf children specifically, are like, because I think otherwise we are easily missed. We are considered a disabled community, but more than anything, we are a linguistic minority. And so I think it would be wonderful for medical students or trainees in their respective areas to get exposure to this life, this whole world that they otherwise would never know. And like you said, you're located right by Gallaudet community, the Gallaudet campus, and therefore the Kendall School. And so that would, again, be a wonderful opportunity if you were to model what the University of New Mexico Medical School does.
And can I say, I've been to Gallaudet University several times. What a beautiful campus. And I always just come away with a smile. It's lovely, and I always feel so welcomed when I go. So I think that creating these collaborations and sort of educational opportunities, that makes a lot of sense. There's a question from the chat about, I don't know if anybody has this information, what percentage of healthcare workers are actually deaf or hard of hearing?
So someone posted, thank you, Amber, for posting the website. So there's an organization called American Medical Professionals with Hearing Loss. And it's a group of, people from all different types of health professional fields that are, some are deaf, who use this American Sign Language, some are hard of hearing, some are, lost their hearing late deafened. So it's a large organizational group. And I think in going back to the first question, they offer a mentoring program. So, I think if you're interested in volunteering and working with the deaf and hard of hearing community, you can sign up and become a mentor to, it's kind of following along with what Ms. Abrams said, but work with younger, high school students or who are deaf or hard of hearing and interested in pursuing a nursing or other health professional field. And they might have they'll probably have some research numbers in terms of what percentage of people are deaf or hard of hearing.
Thank you. Dr. Poorna, what do you think is the biggest misconception of the hearing community when it comes to research professionals such as you from Gallaudet? I feel like things are so segregated. I can not ever recall or remember at any of our medical conferences where a deaf colleague presented, for example. What would you want people to know as a professional, as a researcher, as a deaf woman, are some of the misconceptions, or how would you like to be seen differently or treated differently?
Speaking for myself and on behalf of the broader deaf community, what I would like to see is greater respect for deaf people, as individuals. I would like to see healthcare providers ask a deaf person what they want in terms of communication. While I do think that the ADA was a good step for people with disabilities, it did create some unintended barriers for some deaf people, particularly within healthcare. So there are some deaf people who don't want to communicate via interpreters for a variety of reasons. Sometimes just around privacy, sometimes just lack of qualified interpreters in their area. Sometimes they just are comfortable with their doctor or their medical provider and are happy to communicate directly. Sometimes it's as simple as they don't want to wait around for an interpreter. So there are a host of reasons why people don't want to communicate by way of an interpreter. And yet I've seen situations, I've been in situations like this too, where medical providers sort of force interpreters on the patient. And I would like to see that changed. I would like to see healthcare providers respect what patients are requesting and what they need, and to truly work with their patients and advocate on their behalf so that they can focus on their healthcare. I think that would increase their compliance, their adherence. It would improve health outcomes as well.
You reminded me, I'm of an age where when I came to Washington, D.C. to do my training, it was at the beginning of the AIDS epidemic. And at that time, it was mostly gay men that were dying. Now, I came from Michigan, grew up in Michigan, and it's not like there were no gay people there, but it was just a different time. And coming to DC, especially during the beginning of this horrible pandemic where there were hundreds of people, I took care, I can't tell you how many people I pronounced dead because of AIDS, and it was a 1-year death sentence. And I didn't know a lot about sort of gay male subculture, I should say white gay male subculture. So I asked, I think that saying, teach me about, what do I need to know? I think that I can say as physicians, I don't think nurses are like this, for example, or other clinicians, but we tend to feel the need to know everything, and how can we? And so I think it is about humility as well, humility, giving respect to whomever you're taking care of, but listening ultimately, I think is so key to communication. And when it comes to one's health, how we feel, how we connect with each other is therapeutic. I think we sometimes forget about that. So I'll come to you, Ms. Abrams. What would you wish that we as physicians, clinicians, what do you want us to know or do differently?
A lot of things, I have to say.
Okay, good.
Like Dr. King said, being shown the respect of simply being asked what we want, what accommodations we prefer, as opposed to making those decisions for us. I think avoiding making assumptions is also a really important first step. As a mom of 2 deaf children, I've had doctors who think they know what's best for my 2 deaf children, and not me. And I have to remind them, I am the mother of these children. I know their children. And while I know this certainly happens to all parents, I don't necessarily often see them argue as strongly. Providers often know more than parents, but not always when it comes to a child's inner workings. I think doctors and patients' relationship needs to be collaborative, because at the end of the day, the provider is really working for us. I am receiving a service from you and you are being paid for it. And so I think there needs to be a shift in the power dynamic that currently exists. I would also really appreciate if the medical field became more deaf friendly. It just so happens that in Washington, D.C., we have
You just muted. Mm-hmm.
I'll take it for now.
Thank you.
So people do talk about the doctors who are supportive of deaf people or who respect the community. And so we will choose our physicians and our health providers based on the recommendations of our friends, based on word of mouth. I think that's common among all populations, but even more so for the deaf community. Is the staff and the doctor deaf friendly? Are they connected to a hospital? Are they respectful of deaf people? A couple of years ago, I had surgery and I suspected that I had an appendicitis. And I was fretting about which hospital to go to based on whether or not interpreting services would be immediately provided. So I had to think of my communication access versus my health, and that informed my decision about which hospital I went to. And so I actually ended up going on Facebook at 3 a.m. to suss out which hospital a lot of my friends had checked into over the history of, on those Facebook check-ins. And based on the larger percentage of my friends that had checked into that hospital, I then realized that that must be a deaf-friendly hospital. They must have interpreters, and that's how I picked my hospital. That was a lot of prep time on my behalf for an emergency situation. And some people don't have the luxury of those options. In rural areas, there's often one regional hospital that you must go to. So the point being, everyone needs to have that training on cultural sensitivity, on understanding deaf people's various needs, and be open and willing to accept people for simply who they are within a culture and a language. Respect them for who they are.
I mean, thank you for sharing that story. Obviously, people, when they're feeling sick, they don't necessarily have the wherewithal, the energy, the ability to think about all these things. And we see similar stories that I can think of one instance that the March of Dimes has a video in which an African-American man whose wife actually ended up dying from a C-section because they wouldn't listen to the fact that she was bleeding, had to think about what clothes that he had to wear before going to the hospital because he didn't feel that he could be respected. So I think absolutely, people don't necessarily, the mainstream doesn't necessarily have to go through these flips and, thinking about what they're going to do ahead of time. But this is the reality for people, for the deaf and hard of hearing community and for other minoritized community. And I think that's an indictment of our overall healthcare system that, you know, that people are not being respected as they are, whomever they are. There's a question that just came up on Facebook about whether COVID impacts the deaf and hard of hearing differently in terms of symptoms. As a clinician, I can say I don't think that there is a difference. I know that that every organ system is impacted with COVID, and we actually just had a presentation by one of our ear, nose, and throat physicians who said that it can cause hearing loss. But does anybody on this panel know if there's disproportionate symptoms in, you know, in the deaf and hard of hearing? That was a question. I'm not aware of any. Anybody else?
I don't think there is, but I would add that because of COVID and mask wearing, it's become much more difficult to communicate, because in terms of being able to see facial expressions and, you know, reading lips does sometimes help facilitate communication. And so with the mask wearing, especially in the hospital and clinic setting, it's been more difficult in terms of even more difficult around communication. And so there are, you know, FDA approved clear face masks, as well as people have been making cloth masks with vinyl inserts, so you can see around the mouth, and it helps illustrate like facial expressions. So not necessarily a symptom of COVID, but a product of COVID, the mask wearing.
Thank you. And there is Mr. Stephen Collins wanted to say great discussion, and please don't forget about the deafblind community, because that's obviously another group. But I could talk with you guys for hours. Thank you for educating me and educating our audience. This should be the first of many conversations. And I want to thank each and every one of you for your time this evening. We are looking forward in partnership with the Rodham Institute to get some of these initiatives started so that we can do better at serving our deaf and hard of hearing and blind, of course, communities, and all of our special communities that are so valuable. Every human being is valuable. And so we thank you, we love you, and we invite you back. So thank you again. This has been terrific. I appreciate you. Have a nice evening. Thank you. Thank you. Okay. Take care.